Good evening, one and all. This is Dr. Manvita, Consultant Emergency Physician at Yashoda Hospital, High-Tech City. Welcome to the online webinar sessions organized by the Emergency Department at Yashoda Group of Hospitals on every Friday. This week, the topic is hypertensive emergencies. It is one of the most common conditions for ED visits and ICU admissions. It is one of the most common comorbidity which is neglected because it is most of the time asymptomatic. Today we will go through the common presentations for the ED and how much we can reduce the BP depending on the condition. Today we have a speaker, Dr. Harshita Sridhar, who is an emergency physician and has around 14 years of experience in the field. She completed MBBS from MS Ramaya Medical College and did her MD Emergency Medicine from Vinayaka Mission, Salem. Presently, she is consultant and head at Emergency Department, Manipal Hospital, Millers Road, Bangalore. She is also the Vice President of Semi Karnataka Chapter for the second time in a row. Welcome, ma'am.
Thank you, Dr. Manvita, for the introduction. I'll just share my slides. Is this visible for everybody?
Yes, ma'am. Please start.
Yeah. So again, good evening to one and all. I'm Dr. Harshita, and I'll be here to talk the next few minutes on hypertensive emergencies. So the objectives of the session will be to distinguish which hypertensive presentations require immediate therapy, what are the appropriate therapies in each of these presentations, and describe the risk of the treatment. What are the advantage and disadvantage of the currently available antihypertensive drugs? So you might receive such several cases in your ER, like an asymptomatic 65-year-old with a blood pressure of 200 by 115, or an SAH patient with a blood pressure of 180 by 100. In all these cases that you're seeing, is there anybody who want to unmute and tell me in which cases would I reduce the blood pressure and to how much? Anybody who would like to raise their
They don't have speaking permission, ma'am.
All right. So I hope the audience is able to see these kind of varieties and are able to think to themselves in all these conditions, is there a potential risk? Is there a requirement for reduction in blood pressure? If so, how much of blood pressure I need to reduce? What is my target blood pressure? What's my antihypertensive choices in the ER in such cases? Now, this is what I want you to all think so that we can go forward in understanding this better. So before I go into hypertensive emergency, let's just briefly talk about chronic hypertension. This increases the risk to atherosclerosis, leading to risk to MI, cerebrovascular diseases, renal diseases, and these are all long-term risks. So elevation in blood pressure is often a physiological response to an acute condition. So you don't want to very aggressively treat a chronic hypertension patient as it can increase morbidity and mortality. So patients who come very asymptomatic with increased blood pressure or these chronic hypertensive patients should not be treated as emergency. They're actually rather a pseudo-emergency that are presenting. So with this thought, let's see what are the actual emergency related to hypertension. Is that what we need to look for? So hypertensive emergencies are defined as a rapid decompensation of the vital organ function secondary to an inappropriately elevated blood pressure. This requires you to reduce the blood pressure for the first 1 hour to decrease the morbidity. But again, here we're going to talk in the coming slides as to how much of blood pressure that I need to reduce in this 1 hour. And where is this? Basically, the target vital organ damage that is happening, you're trying to reverse that physiology of it, and you're going to reduce the blood pressure only to reduce the vital organ damage. What are the different types of hypertensive emergencies? In CNS, you can have hypertensive encephalopathy. In cardiovascular conditions, you can have an acute MI and hypertensive emergency leading to an acute MI, cardiogenic pulmonary edema, aortic dissection. In renal conditions, you can have failures, eclampsia, or in conditions where there is catecholamine excess, you might want to consider all these as hypertensive emergencies. So what is hypertensive urgency then? There are two concepts under hypertensive crisis. It's it's an umbrella to the ER where you have hypertensive urgency and emergencies. So urgency is a potential rise in blood pressure, but has no organ damage evidenced. But however, there is a potential to go into an hypertensive emergency. In such cases, you also treat these cases in the ER. There are a few cases which are controversial to be called as emergencies and urgencies. That is, you have a raised blood pressure with retinal changes, but without any encephalopathy or acute visual symptoms. Or they can be high blood pressure with non-specific symptoms like giddiness, dizziness, and headache. And very high blood pressure is without symptoms are mainly called as hypertensive urgencies. So this generally has an elevation of blood pressure of a systolic more than 115. There is no progressive end organ disease. So the National Joint Committee initially stated that, the guidelines that they have recommended is to reduce this blood pressure slowly in 24 hours. Rarely it requires urgent therapy because gradually reducing the blood pressure reduces the risk of cerebral and myocardial ischemia. We will eventually learn this more. So before we come into further about hypertensive emergencies, let's talk a little bit about the physiology and the pathophysiology of these conditions. So what is cerebral blood flow? Cerebral blood flow is directly proportional to the cerebral perfusion pressure and inversely proportional to the cerebrovascular reactivity. And cerebral blood flow pressure is measured as MAP minus the ICP. And mean arterial pressure is, how do you calculate the MAP? It is the diastolic blood pressure plus the 1/3 the pulse pressure. So you're also aware about cerebral autoregulation. This is normally happening at 50 to 150 millimeters of MAP. And normally the blood pressures are ranging between 70/40 to about 190/130. So anything below this or above this, the autoregulation does not happen. So what happens when the MAP falls below? The cerebral perfusion pressure, there is more of hypoperfusion leading into ischemia. Or if the cerebral perfusion pressure goes above the limit, then you will have a force-mediated dilatation causing vasogenic edema. We have to remember here, when we spoke about cerebral autoregulation, you realize that between 50 to 150, there is an autoregulation that is happening to maintain the cerebral perfusion pressure. But what happens in chronic hypertensive? There is an adaptation. There is the cerebral blood flow moves, there is a shift to the right. And if you look at the graph here shown here, in such patients, if you start reducing the MAP too much, you might rather cause a quick drop in the cerebral blood flow. Even other medical conditions like ICH, SAH, cerebral edema can also show a shift in the autoregulation MAP. So you want to be very cautious when you have these conditions where you're trying to reduce the blood pressure, because you reduce it below the autoregulation cutoff, you'll end up causing hypoperfusion to the patient, cerebral hypoperfusion. So what actually happens in an hypertensive emergency? This is mainly seen based on the rate of change of blood pressure. So a rapid increase in blood pressure is highly likely to cause a hypertensive emergency. However, in patients who have chronic hypertension, the probability of causing damage to the end organs is less likely because over the time they develop vascular changes which protect the end organs from these acute change. So it is important that you take a history of hypertension in these patients who present with high blood pressure. And then you want to evaluate your treatment based on the past history also. If patient has been normotensive, like conditions where it's a pregnant woman coming with eclampsia or an acute glomerular nephritis, and these patients may develop signs and symptoms even to blood pressure as much as 150/100. So it again matters whether the patient has been a normotensive or a chronic hypertensive when you're trying to treat such hypertensive emergencies. So as we spoke about the pathophysiology, so there is a sudden shoot up of blood pressure and this autoregulation fails and there is an increase in the resistance, causing vasoconstriction in the vessels. Now vasoconstriction causes activation of the renin-angiotensin-aldosterone system and causes endothelial injury, leading to ischemia and target organ damage. What are the general characteristics of hypertensive crisis? Usually the diastolic blood pressure in a patient is usually above 140. There might be fundoscopic changes as in hemorrhage, exudate, and papilledema. Patient might likely to be having complaints of headache, confusion, might be Stuckress, might have visual loss, focal deficit, seizures. In cardiovascular system, you can have an cardiac enlargement and congestive heart failure features. They could be reduced urine output. And in gastrointestinal, the patient can have nausea and vomiting. So now that you have identified a patient with an hypertensive emergency, what do I need to do now? What are my therapeutic considerations? I need to look for rapid reduction of the blood pressure to ensure that the organ damage is not progressed. At the same time, I should also pick the right drug and also be aware of the complications of the therapy. So now let's see what are the drugs that I need to choose in these conditions. The question also comes is, how far can the BP be safely lowered? Remember the thumb rule, you should always, the lower limit to reduce the blood pressure is only about 25% below the mean arterial pressure of that presentation in the patient. 50% of chronic hypertensive would have reached this lower autoregulation limit even with just 11 to 20% reduction in your MAP. And 50% have lower limit above the usual mean. So you will rather cause ischemic complications like blindness, paralysis, coma, death if you rapidly reduce the mean arterial pressure by more than 30% in that first hour. So be very cautious that you would not want to reduce your blood pressures too rapidly. So do not lower the blood pressure more than 20% for the first 1 to 2 hours unless it is really mandated. Decreasing the diastolic blood pressure of 110 or patient's normal may not actually be the safe plan, and you want to do the reductions more gradually. When you're reducing the blood pressure in patients, closely monitor their neurological status. So now what are the drugs that I need to take? Is there a chat question before I move forward? Nitroprusside. This is an arteriolar and venous dilator. It is very effective in lowering the blood pressure. It is given as a dose which can be titrated. The usual starting dose is about 0.5 mics per kg per minute up to 8. Remember that you want to be cautious in patients who have renal dysfunction, as it can cause potential cyanide toxicity when you're giving a prolonged infusion. But it is a very potential drug, very rapidly acting, and can be titrated. Nitroglycerin or NTG infusion. This is mainly more of a venodilator at low doses and has significant arterial dilatation in the higher doses. Again, very effective, more commonly used in patients who have cardiac complications. The dosages are somewhere between 5 to 10 that you initiate, and you can titrate and increase it up to 250 mics per minute. You dilute them in D5 when you're giving it. So as we mentioned, it has a rapid onset and offset, and it has an ability to smoothly titrate the blood pressure. Problem is, if you go unattended, there can be a potential hypotension and causing further end organ hypoperfusion. So this requires to be given as a continuous infusion and requires prompt monitoring of the patient. And if not seen correctly and there is an hypoperfusion, it can lead to it can affect the cerebral autoregulation. Sublingual nifedipine. It causes peripheral and coronary arteriolar vasodilator. It's a coronary arteriolar vasodilator. Again, this also has a rapid onset within 5 to 20 minutes and peaks by 30 to 60 minutes. It causes potential hypotension and reflects cardiac stimulation in terms of increased heart rate. So there are several case reports with sublingual nifedipine that there is cerebral and myocardial ischemia. And this drug was earlier very commonly given by physicians to say to patients who had high pressures at home, over the counter or on the phone, saying that take a sublingual nifedipine and the blood pressure would drop in. But there are many case reports that came out saying that sudden drop led to many cerebral and myocardial ischemia. So now the awareness has increased, and we do not very commonly advise sublingual nifedipine. It should be, if it is given, it should be given under monitoring. Labetalol, you all know it most common in the ER. It has both alpha and beta adrenergic blockade. It has all the regular contraindication to a beta blockers, that is in asthma, COPD patients, patients who have bradyarrhythmias, you do not want to give labetalol. It has a very rapid action. Its onset is less than 5 minutes. It peaks in 10 minutes and it lasts for about 2 to 6 hours. The first dose is usually about 20 milligram IV bolus. You can go up to 40, 80 in every 15 minutes and up to a maximum of 300 mg. Dioxide. again, very rapidly effective as an IV bolus, but it has a potential hypotension and it's long lasting, leading to cerebral and myocardial ischemia more rapidly. And with the market reflex response to the heart in terms of increased heart rate and cardiac output. So this is rarely used as a first line drug, but in case of an malignant hypertension, you can consider these kind of drugs. Hydralazine, I think this is more commonly used only by the gynecologists, obstetricians. Hydralazine has an unpredictable hypotensive effect, and it has a delayed onset compared to the other parenteral agents. However, this is still a traditional therapy used in preeclampsia and eclampsia. This can affect the cerebral autoregulation, so you generally choose to not give in other hypertensive emergencies. Furosemide or Lasix, it's a loop diuretic. It also has a rapid action and a shorter duration of action. It can also, remember, furosemide lowers the blood volume, the blood potassium, and thyroid hormones, especially in long-term use. This is more of an adjuvant therapy in hypertensive urgencies, and it is particularly used in patients who come with fluid overload, like you have a congestive heart failure or a renal condition where there's an initial CKD patients or an AKI with fluid overload is when you will use Lasix. The dose in hypertensive emergencies can be about 40 to 80 milligrams IV, and this is only an adjuvant drug. Clonidine, it is a centrally acting alpha agonist. It decreases the sympathetic tone to the heart and the peripheral vessels. It's about a 0.1 to 0.2 milligram of a tablet, which is given per oral. And the onset of action is in 30 to 60 minutes, peaks in 2 hours, and duration is for about 6 hours. You can give repeated doses to titrate, more commonly used in renal disease patients, but it's rarely a first-line agent in hypertensive emergencies. ACE inhibitors is IV enalapril or oral captopril. This is also potentially useful for reduction in acute blood pressure. But however, there is a little clinical experience in patients with hypertensive emergencies, as it is difficult to titrate. Some of the newer agents, phenolidipine, it's more commonly used in renal conditions. It's a peripheral dopamine 1 receptor agonist. It causes vasodilatation, renal artery vasodilatation, and natriuresis. Other drug, nicardipine, it's a calcium channel blocker. Management of specific hypertensive emergencies. So if there's an hypertensive encephalopathy, there is an abrupt sudden increased blood pressure that's exceeding the normal limit of the cerebral autoregulation, causing the vasospasm and the edema that we already spoke about. And patient comes to you in the emergency with headache, nausea, vomiting, confusional states. Patchy neurological deficits could be there. You've done an ophthalmoscope, you check this for papilledema and retinopathy. So now you need to reduce the blood pressure to resolve these symptoms. So your target is to resolve the symptoms. So other differentials to hypertensive encephalopathy can be stroke, intracranial bleeds, intracranial mass, and encephalitis due to infections, drug ingestions causing encephalopathy, etc. Hypertension with stroke syndrome. Now the need for BP therapy is controversial. Whether increased blood pressure causes a rebleed or an hemorrhagic transformation, increased edema, increased ICP. These are the controversial statements. Versus if I reduce the blood pressure, what happens to my penumbra region? Am I worsening the ischemia around the ischemic insult to the brain? So hypertension is generally transient and a physiological response which can resolve spontaneously. So you want to cautiously reduce the blood pressure. In subarachnoid hemorrhage, the chance of rebleed is 20% within 2 weeks, more so in the first 24 hours. So there is an increased risk which has been proven when the systolic blood pressure is more than 160 or a MAP of more than 110. However, there are not many studies that show that the treatment of BP reduces the risk of rebleed. Acute right shift of the curve happens as we earlier discussed. So you want to give drugs to reduce the blood pressure to a target of around 160. And the most common drug that we can consider in SAH is tablets of nimodipine tablets, which has more cerebroprotective action. Intracerebral hemorrhage. Hypertension is associated with increased mortality, and hypertension may be a marker of more advanced chronic arterial compromise. There is a physiological response to increased ICP from the clot. Decreasing in blood pressure may increase the ICP. This ischemic penumbra, again, that we are talking about, may exist in the intracerebral hemorrhage. However, the reduction of blood pressure is only to a certain extent that you want to reduce it down, because there is no evidence to say that it will reduce the actual risk of hematoma expansion or a rebleed. You want to maintain a higher MAP to maintain the cerebral perfusion pressure. Aortic dissection. As you're aware, there's a tear in the intima. So 50% mortality is seen in the first 48 hours. So even if you have the highest suspicion of the diagnosis, ensure that you reduce the blood pressure. You want to target the systolic blood pressure between 100 to 120 and a heart rate of less than 80. Some of the common drugs that you use in aortic dissection is propranolol, nitroprusside, labetalol, or trimethopam is a ganglion blockade drug. Once you have controlled the pain, the contractility, and the BP, then you can take this patient for an iotogram or a CT transesophageal echo. Patients who are presenting with high blood pressure and acute LV failure or in myocardial ischemia, the hypertension is increasing the afterload and worsening the failure. Also remember that the anxiety and pain can also increase the blood pressure. So you want to give specific drugs to control the blood pressure in these cases. I hear the adjuvant therapies with furosemide is also being considered. Preeclampsia and eclampsia. The standard therapy we discussed was hydrolysine. Other drugs are nifedipine, labetalol. Do not consider nitroprusside as there is a risk of fetal toxicity. The definitive treatment in eclampsia is magnesium sulfate and delivery. So I think I have managed to speak about the physiology of cerebral autoregulation and the importance of maintaining MAP to maintain the cerebral perfusion pressure. So in which conditions would you actually want to target a rapid reduction? In which conditions you want to maintain a higher MAP? And what are the drugs that we want to choose? So we'll go through the cases once again. In an asymptomatic 65-year-old blood patient with a BP of 200, 115, what do you think this case is likely to be? It can be an hypertensive urgency with a high potential for this patient to develop a possible organ damage. So in this condition, you want to reduce the blood pressure by only about 20%, and then you want a slow reduction over the next 2 to 3 days. If there is an embolic CVA with a blood pressure of 215 and 105, and you want to probably thrombolize the patient, he's in a window period, you want to again target the blood pressure of reduction of about 15 to 20% only, and reach a systolic and maintain a systolic blood pressure of about 180. Hemorrhagic CVA, again, you may not really want to do anything much with the 200 pressures, or just marginally reduce the blood pressure with a dose of labetalol. There is an SAH case with a BP of 180 by 100. What would I want to do? Till we plan for clipping, you want to reduce the blood pressure and target a systolic blood pressure of less than 160, or about a 20% reduction of the systolic blood pressure. Aortic dissection case, you have a blood pressure of 175 by 105. You want to rapidly reduce the blood pressure, and you want a systolic blood pressure between 100 to 110, and also reduce the heart rate. In a pregnant female, 150 over 100, but has coming to you with features of preeclampsia or eclampsia, you definitely want the pressures to be reduced. Encephalopathy, till the symptoms are resolved, you want to reduce the pressure. You can consider IV infusions with nitroglycerin or nitroprusside. Acute pulmonary edema, again, till the pressure on the heart or the load on the heart reduces, you want to reduce blood pressure. After the initial 20% reduction, then you would go in for a gradual reduction. So I would like to conclude here that differentiate hypertensive emergencies from hypertensive urgencies in your ER. Hypertension associated with cerebral infarction or intracerebral hemorrhage rarely requires treatment in the emergency. So remember to keep your blood pressure on the higher side. You have many titratable IV hypotensive agents, so consider them. From some of the common drugs that you can use is labetalol, esmolol, nicardipine, nitroprusside. These have rapid IV actions. Thank you.
Thank you so much, ma'am, for such a wonderful session. The examples with the cases and how to handle them is really very helpful. And I'm sure the session gave a clear idea as how to deal with the hypertensive emergency cases. Looking forward for many more sessions like this. Thank you so much, ma'am.
Thank you. I thank Yashoda team and Semi for this opportunity. Thank you for the arrangement.
Any questions?
This is the next week.
Okay, this is the next week webinar session, the Journal Club. Studies on the SALT ED and SMART basics on 13 Jan.